Good afternoon and welcome to United TV. My name is Kemal Erkan. Today is July 19th, 2024. Today we have another special session focused on exploring different types of bariatric surgery. Whether you are considering bariatric surgery for yourself or for your loved ones, this is the episode for you to learn more about different bariatric surgery types. As usual, we have Dr. Isaias Irgau with us. He's one of the most experienced bariatric surgeon, not only in Delaware, probably in the United States. Dr. Irgau is giving his clinical insight and making sure that what we have today, what we are discussing today, is all coming from the clinical base. And I will be helping him with some of our questions, and we'll make sure that you have a good understanding of what type of surgery you should be getting if you are considering bariatric surgery. Dr. Irgau, we can do camera on. Now, today is a special day for us because it's the first time we do this together in the same room. So it is a little bit different, right?
Great.
Great. I'm used to having him on the other side of town. But today he's in our studio in our new office. So we are kind of lucky to have a very nice studio here. So, Dr. Irgau, how are you doing?
I am doing fantastic, Kamal. This is just a great setting. I'm very happy to be here for yet another bariatric Friday.
So, Dr. Irgau, this is our new cycle as well. So we have done so many full cycles, and this is the first episode. It's not easy to cover these from different perspectives, but somehow we are able to manage that. But what I did for our patient, we put these same topics in one playlist, so they can actually watch maybe 5-6 different bariatric surgery types videos. Just going to the playlist and then just do that, and they don't have to necessarily just watch one or two. They can do the whole thing. So, but just to have a background in different surgery types, you have been doing this for almost 24 years now.
Yep.
What are the different types of bariatric surgeries, and then we're going to go into specifics.
Of course. So bariatric surgery, of course, as we've said many times, is the most effective treatment we currently have for severe or morbid obesity. When obesity has gone to the extent where there is really a risk or the development of several illnesses related to obesity that could be life-threatening, whether it's diabetes, high blood pressure, sleep apnea, or the really development of different cancers, which happen to really find a fertile ground in obesity. So when obesity gets to those levels, and typically we're talking about somebody who's 80, 90, 100 pounds or more above their ideal body weight, not only there is this risk of these illnesses, but it is extremely difficult to get rid of the weight without an effective treatment like bariatric surgery. Bariatric surgery now is a very well established, safe treatment that is really advocated by doctors in the United States when their patients present with extreme levels of obesity.
So I'm running a video for people to kind of see different images. Obviously, we may not be on that specific type while we are talking about it, but that's going to run in a loop. We want to probably start with bypass first.
Sure.
What's bariatric gastric bypass? What is that procedure? Who should be getting it? What's the best candidate for that? We can start with that and then we'll go to the
Absolutely. So all bariatric procedures as surgery entail some kind of change to the upper portion of the digestive tract. And we're talking about the food pipe or the esophagus, the stomach, and the early portion of the intestine. With gastric bypass, what we do essentially is we partition the stomach. We divide the stomach between a very small portion still attached to the food pipe and the rest of the stomach. And we separate these two portions of the stomach completely. And then to restore continuity so that the food that comes from the food pipe into the little stomach can get into the rest of the intestine, actually we reroute the intestine and we attach a portion of the intestine to that little stomach, bypassing the larger stomach and the early intestine. That's why it's known as gastric bypass. Gastric bypass really has been established as the gold standard of bariatric surgery because that's the one that we have developed for many years. In fact, early in our career, about 22 years ago, gastric bypass was the procedure we did the most. Okay? It's a very effective procedure. It has excellent results, and nowadays it can be done laparoscopically. In fact, in our center, very often we do it as a day procedure where patients come in, have gastric bypass, and go home at the same time, right? Excellent results. And really, anybody who has morbid obesity could be potentially a candidate for this very well-established procedure. However, gastric bypass really has been pushed aside a little bit by the arrival of another very powerful procedure, but less invasive procedure, which is the gastric sleeve. So although the vast majority of patients who have morbid obesity could be candidates for the gastric bypass procedure, we don't necessarily offer the gastric bypass as the first line procedure. We offer them the gastric sleeve. The gastric sleeve is less invasive than the gastric bypass.
Just before we go to that, with gastric bypass, what we are saying is you're a young person, let's say, and you don't have diabetes, like severe diabetes, you don't have refluxes, and also we do EGD to see if there are issues, structural issues in the stomach. So, and if there is no clinical need for you to have a bypass, you should not get a bypass as your first option.
Totally. Right. I think that's a fair statement, Kemal. I mean, clearly all procedures are appropriate because they're well established, right? But really, if somebody can do the same, can get the same results with a less intrusive procedure, right? Like the sleeve, there is no need to go with the gastric bypass, right? So there's no really need to do a very long run for a short jump, as they say, right? The gastric sleeve, in the vast majority of times, can give the same or similar results to the gastric bypass to the vast majority of patients who are looking for bariatric surgery, and therefore we don't necessarily offer the gastric bypass as a first-line treatment. Clearly, I want to state here, Kemal, that the choice of procedure is something that should be decided between the surgeon and the patient. It's not something we prescribe necessarily, but it is our job, obviously, to inform patients with our knowledge based on years and years of experience, having operated on thousands of patients over the time. So, for somebody who has morbid obesity, as you say, they don't have severe reflux, gastric sleeve will absolutely do as the first line procedure, and it will give the similar results to gastric bypass. Now, it is important to clarify the issue of reflux here, Kemal, because yes, there is some truth about reflux and the need of gastric bypass, but a lot of what is talked about is actually a myth, right? Somebody who has some reflux would come to our office saying, I can't have the sleeve because they read something about that online, right? Mm-hmm. It is not true. The type of reflux that would negate the gastric sleeve is really severe type of reflux that really affects only a very small minority of patients who have reflux symptoms. And that is something, obviously, that we diagnose after we do endoscopy, which is one of the preparation procedures that we do before bariatric surgery. So it is really fair, as you stated, Kemal, that the vast majority of patients will do absolutely well with the gastric sleeve as the first line of treatment, right? Now, who are the patients on whom a gastric bypass might be placed? Well, these are a minority of patients, for instance, that would have very severe reflux. And some bariatric surgeons also feel that patients who have a very difficult to treat diabetes, right? Diabetes, which is really difficult in its response to medications, those patients might be better with the gastric bypass, because gastric bypass definitely has an edge in its impact on the resolution of diabetes when you compare it to gastric sleeve. Again,
so it's when we are not able to manage it with medication. Like I see some patients who have reactions to like metformin, so they're not able to take it. They try different things and it doesn't work for them, and then A1C is still high. So that in those cases, this would be the right way to go.
absolutely. So we're talking again in a small minority of patients. Again, it's not all patients with diabetes, but again, patients when they come to my consultation, very often they are very happy to listen to my advice, my experience based on what I've done, and they will ask questions. But there may be some patients on whom certain ideas may be so set based on experience through family members and friends. They may say, you know what, doctor, I just want the bypass. And if that is the case, absolutely. These are procedures that are appropriate for all patients requiring bariatric surgery. But as we mentioned earlier, the vast majority of patients will do well with the sleeve. Now, it is important, just like I described what the changes were with the gastric bypass, that we describe what the changes are with the gastric sleeve as well, right? With the gastric sleeve, the main difference is that the intestine is left in its natural place and situation. We don't reroute it, we don't cut it. All the surgery is focused on the stomach itself, that larger organ. And what we do essentially with the stomach is we divide it so that the stomach, which is naturally the shape of a watermelon, when we're done with the sleeve, now has the shape of a banana. It's much slender, it's much tubular. The larger distending portion of the stomach is the portion that you see. Now, it is definitely true that a lot of the results from the sleeve come from the fact that now the stomach is small. It doesn't have a lot of volume. Therefore, when the person eats after they've had the sleeve, they will feel full early and they are going to be hungry less frequently. But there are other effects of the gastric sleeve as well. By removing the portion of the stomach which is distensible, we're actually removing a metabolically active portion of the stomach that communicates with our brain to promote storage of fat, right?
And
so by removing
many people don't understand that, right? So when we say we are cutting part of the stomach, so they're like, so what, right? That's not so what. So that part is the part that communicates with the brain.
Absolutely.
It's almost, it has its own personality. Like they kind of just,
they do. I mean, the gut is known as the second brain because it is so much more involved in its communication with the brain, and rightly so, because our digestive tract is so critical in our energy balance. But the way how our body has evolved, essentially, it favors storage of fat, right? Our body is not designed to lose weight. It doesn't know how to lose weight, right? It knows how to gain weight, but it doesn't know, right? So all the systems are really optimized for storage of energy, which means for increasing weight. Once we remove
I have a picture right now, Dr. Irgau. I don't know if you're able to. See, I stopped the video for a second just for because I want people to really understand this. So this comes up as a question from patients and from others, from providers, from physicians as well. So the part that we are removing is the part that makes us hungry. That's right. As it happens, the picture we have here is actually the sleeve plus the vaginal switch. So I don't want people to get confused because there is rerouting of the intestine as well. So if you have one where we just have the removal of the, and I think you had it a moment ago. I have it. I mean, this as you're correct. When you look at the stomach, that's essentially how the stomach is divided. But this is showing the sleeve plus the vaginal switch, which is obviously a different procedure. But it's coming. But the idea again is that a portion of the stomach that we're removing is not just food storage portion of the stomach, but it's also a very active portion of our organ that once it's removed, it deprives the body from its
mechanisms of fat storage. That's why it's so much easier to lose weight after the sleeve is done, for instance, as opposed to a diet that gives you an equal amount of calories, right? You can decrease your calories with a certain diet, but you know that after a while, the weight loss stops. It's not the same thing with the sleeve because, yeah, absolutely.
It's kind of like the picture is not the best one. I'm going to get a better picture for us.
Absolutely. So essentially, by removing that distending portion of the stomach, we are making the person metabolically different from what they were before, right? Now they are able to lose weight. The body is much more permissive about weight loss. That's why they are able to do that. So metabolically, we can become much healthier now because not everything is geared towards weight gain. Everything now is much better balanced. That's why people are able to lose weight. So it is important to emphasize here that the results from the gastric sleeve are not just purely mechanical, but they are metabolic as well.
Now, a couple weeks ago, we did a gastric balloon as one of the methods, not necessarily for morbid obesity, but I think maybe on the lower side of morbid obesity, but more on the higher side of obesity that we choose to go with. I mean, we can briefly mention that since we just did that session, we don't need to go into the details.
Yeah, no, absolutely. So it's the least invasive procedure we have. You're absolutely right. We don't. It's indicated for class 1 and class 2 obesity and not necessarily for morbid obesity. And it's a procedure that is transient. It's completely reversible and it's not surgical. In other words, there is no incisions that we make. The balloon is inserted endoscopically, but then after 6 months, it has to be removed. So the indications for the balloon are limited from that point of view, but there is clearly a section of the obesity suffering people who would benefit from the balloon outfit. And of course, as our practice, as being an all-rounded bariatric practice, does offer the balloon as well.
Sure. Now, we should mention the gastric band, just so that it will be my transition to the revision surgeries. We don't do the band anymore as much as we used to. That used to be the #1 procedure 15 years ago. But today, that's not really happening. Anything you would like to actually cover for band?
So when the gastric band was first launched, Kemal, it became very popular. Became popular because it was a procedure that was seen as an alternative to gastric bypass, because these were really the only procedures really available at the time. Gastric bypass, very extensive changes, and then came the band, which is a device that you put around the stomach. No cutting, right? And also it's a device that could be removed. So there was this sense that it was a potentially reversible procedure. And it's still a valid procedure. But the device itself, with its presence in that upper portion of the stomach, in the long term, does create problems, particularly in the quality of life, right? It's not predictable when the person will be able to swallow their food without any difficulty, as opposed to being sick. That really interferes with the quality of life. Secondly, the weight loss itself, there is clearly a difference between the band, the sleeve, and the gastric bypass in terms of weight loss. It's not as powerful a procedure as the sleeve or the gastric bypass when it comes to weight loss. And then there is the added issue of having to do adjustments of the band. You know, patients have to come to the office from time to time to have their band tightened or loosened, right? And because of that, we actually have seen way more band removals in recent years as opposed to band replacements. And I think the availability of the sleeve as an option to bypass actually has pushed out the band as an other alternative to gastric bypass. So we are seeing a lot more of that. But we still see patients who had the band for many years and who are doing very well. We still see patients who struggle with the band and have their band removed, and then we move on to a different procedure. And our practice still manages band patients that require adjustment, whether it's removal of the fluid or additional fluid. But as you correctly said, it as a primary procedure, we don't perform it as nowhere near as frequently as we used to in the past.
Sure. Now, the other part of the, I guess, the surgery times, up to now, we are talking about bariatric surgery times, but when it comes to revision, although they are also bariatric surgeries, but we put them under revision surgeries. So starting from band, there are several different ways to have a revision. And one of them would be going from band to sleeve or band to bypass. So can you explain that process, how it works for those who are planning to, let's say if someone had a gastric band 15 years ago, now they're looking for other options, and then sleeve is where they want to go, what process they would have to go through?
So they would have to go through a similar process than, as a person who's starting bariatric surgery, because they really need to be educated about the differences in terms of lifestyle afterwards, right? So, and also go back to the basics again. We have to have a multidisciplinary evaluation, which would include the nutritionist, very often the psychologist, but also making sure that the person is healthy enough to undergo the procedure, so their hearts, their lungs, and everything has to be prepared optimally. Now, it is important to understand that the band itself creates a lot of scar tissue around the stomach, and that scar tissue by itself can be a potential for increasing risks of complications. So what our choice is in our practice, Kemal, is to have the band removed first and let the person heal and the scar tissue mellow a little bit for 2 to 3 months before we take them back to do the revision surgery, for instance, to the sleeve. Now, it is important to sit down and discuss with patients that revision surgery does increase the risk for complications from, initial surgery, just because there was no scar tissue when we first did the procedure, essentially. And scar tissue does not heal as well as virgin tissue that hasn't been operated on. So it's important for them to understand that. And also revision surgeries that is undertaken by experienced surgeons. Because of that, surgery requires knowledge of anatomy, Kemal. And then when there has been previous surgery, that anatomy gets disrupted, and the surgeon has to be experienced enough to understand this disrupted anatomy and perform the procedure, which means that it needs to be performed in very experienced centers. And our practice, having been doing this for many years, does have the experience to do revision surgery, and we do, of course, a lot of revision surgeries as well. So bands, remove them, wait for the healing process to occur. The person will go through the multidisciplinary preparation, and then we can undertake a sleeve gastrectomy after that.
And for those who may be kind of questioning or asking this question, like why someone had a band, now they have to go through another surgery, this is the same thing that we mentioned earlier. If that was that time, that was the best option. Maybe it was the only few options, because sleeve wasn't there until 2010, right, Dr. Ergau?
Absolutely, yes. Yep.
So when there are better techniques and better methods, of course, we are going to improve. So a lot of people, they have a lot of, they benefited from having a gastric band, but those who didn't have other options. So this is why we are saying that you don't have to go with the, like most maybe, not necessarily complicated, but could be most complicated in terms of like bypass. If you're a younger person and you don't have other comorbidities, this would be the time where you can actually look into going from band to gastric sleeve, which we are talking about like 3-4 month period, which doesn't really add as much, right, Dr. Ergau? Because our patients, by the time we prep them, that takes about anywhere from 9 to 12 weeks, because all the clearances and everything that they need to get. Now, there are those who would go from band to bypass. Are the same rules applying in terms of the conditions and criteria that we are choosing for those?
Yes, and it is important to mention in this case, Kemal, that there may be more of a case to go from band to bypass than to go to bypass initially. And the reason for that is, with the presence of the band, many people may have developed irritation of the food pipe that you want to protect from acid in the future. So it is not uncommon to go to bypass as a first choice after the removal of the band, particularly after you've investigated with endoscopy and assessed the food pipe and so forth. There is a school of thought among some bariatric surgeons which says that if somebody hasn't done very well with the band, they should go automatically to bypass, just because they're thinking, well, the band is more or less a restrictive procedure. So going from one restrictive to another restrictive procedure like the sleeve does not make any sense if the person hasn't succeeded totally. I'm not sure we should adopt this dogma necessarily, because everybody is different. So it is important to really have an in-depth conversation with the patient as to why they have struggled, as to why that revision is necessary, and obviously for them to understand the implications of going to sleeve or to bypass. That's a very individual conversation that we have to have with the patients, but obviously both options are there. Again, many patients would rather go to sleeve first as opposed to bypass because of the implications, long-term implications of bypass. But it is our job, obviously, to educate them onto whether that is really appropriate in their particular individual situation.
And even though it's a small, very small percentage, but there are some people, they would have band over bypass, right? Not band over sleeve, but band over bypass.
That's correct. That's correct.
That's very little. I have seen it in case there is one questioning.
Yeah. So yeah, I mean, not all the surgeons at CRIAS offer this option, Kemal, but it is offered, which means that for some patients who've had gastric bypass many years ago and are struggling with weight regain, then tightening that portion, that connection between the intestine and the stomach with a band around it is an option. There are many issues that need to be discussed there, because having a foreign object around that connection is not something that can be taken lightly, right? So again, when you discuss options for revision, particularly after gastric bypass, there are not very many surgical options, right? But band over bypass is a potential. Again, not all the CRIAS surgeons offer it, but it is something that in some circumstances could be appropriate and perhaps even work well.
Sure. In terms of other revision surgeries,
so the one procedure we haven't obviously mentioned is the duodenal switch, Kemal. The duodenal switch is the procedure that is not done as commonly, but it is a procedure which is in a way similar to gastric bypass, right? There is clearly a removal of a portion of the stomach, just like the sleeve, but then the stomach is reconnected to a much lower portion of the intestine. And at the end of the procedure, the portion of the intestine that will be processing, digesting, and absorbing nutrients is much, much shorter than the gastric bypass. And the duodenal switch is the procedure that really offers the best in terms of total weight loss in the long term. It is very powerful with diabetes, but also it is the one procedure that will have the most implications long term in terms of vitamin deficiency, perhaps change in bowel activity like diarrhea. So it is offered in our practice. It's not as commonly done as the sleeve or the gastric bypass, but it's an option that we offer, particularly with patients who had the sleeve already and they are struggling to lose all the weight that they wanted. The switch is one option that we offer as well.
So now for those who may be in the middle of making this decision, one of the things that we do is an EGD and endoscopy, upper endoscopy. And if someone decided to go with gastric sleeve, but then we find out that they have Barrett, there are a couple of ways that we kind of go by. Either patient doesn't have any problems with going with bypass, or if they have any doubt, or if there are any clinical other conditions, that we may actually repeat the EGD second time to validate the first one. In some cases, I know that patients do come back with questions like why they have to go through this. So when you say Barrett, I know what it is in terms of what we need to do and what we don't need to do. But for those who don't know what it is, if you can just explain that so that those patients can benefit from?
Yeah, absolutely. So Barrett's disease describes essentially a condition in the lower end of the food pipe, that end of the food pipe that immediately connects with the stomach. And in that is a condition that develops after there has been irritation of the food pipe over a long period of time with acid. Now, the potential risk of Barrett's disease is that tissue, that lining, could sometimes, in a small fraction of people, that can change itself into cancer, right? So cancer of the food pipe could potentially develop in some fraction of people who have Barrett's disease. Now, if that is the case, it is important to minimize ongoing irritation of that area with acid. Well, you cannot avoid that with the sleeve, because the sleeve has the stomach still connected to the food pipe, and acid will continue to bath that area. So theoretically, we want to avoid that. So if we discover Barrett's, we say, look, probably the better option for us in terms of achieving weight loss would be to go to gastric bypass, although gastric bypass has its own drawbacks, because in this particular situation, we want to minimize the risk of potential evolution of Barrett's disease in something more sinister like cancer, essentially. Now, all these are theoretical considerations, of course, and there are maybe other considerations also to say that, if a person were to develop, cancer of the lower end of the food pipe, then having an intact stomach is important for the future surgery and so forth. These are all theoretical considerations, but still valid. But at the end of the day, Kemal, it is very important to understand that the most critical discussion is the one that occurs between the surgeon and the patient at the time of consultation. And why is that? And it is because everyone is different. Everyone is different in terms of their actual medical condition. So yes, patients will be likely to have Googled and come up with some conclusions about what may something mean or not, but Google does not write about that individual patient, right? Google writes generalized information, which often may not be accurate as well, right? Or may not be applicable to a particular situation. So that is why you and I have these informative discussions on our Bariatric Friday, but ultimately our patients are going to decide on their treatment course after they come to our practice for a consultation, where we have extensive discussions after review of their medical condition. And that discussion is actually ongoing. As you know, our patients have to go through a fairly extensive process of evaluation with nutritionists, with psychologists, and other specialists, and they will be meeting up with their surgeon on a number of occasions through that process. And those occasions will be important for them to continue that discussion so that they feel comfortable with the choice they make about what is ultimately better for them.
Well, we don't Google anymore, Dr. We do ChatGPT. So a little bit more advanced now, a little more sophisticated, but still not as good as the initial consult that they would have with a surgeon. Now,
I bet if I say ChatGPT instead of Google, many people may not know that yet.
They probably do.
Google has pervaded our language so much now to replace research.
Now we upgraded. So now, dealing with patients, communicating with patients on a daily basis. I know that not everyone is able to make this decision on their own, but then there are way too much out there where it kind of probably influence the patients in the wrong way in terms of what's right and what's wrong with them. Do you find patients coming to the office for the first consult, they kind of like opinionated? So they already know that this is what they are going to do, even if you told them, no, this is not the right thing for you. Or is it
Naturally. So, because first of all, this is a decision that evolves over time, right? They think about it maybe even as long as 2-3 years prior to actually taking action and coming to the office. So through that time, they will have had experience and interactions with people who may have had the surgery before, and they may have seen results that may have been appealing to them or not. So they will form an opinion as to what they want. And as I said, in the vast majority of cases, actually, we are able to accommodate what patients are comfortable with, right? But it is important, of course, for us to go with them through their individual history and then counsel them at what might be best. I can tell you, and you probably have the numbers as well, the vast majority of patients are undergoing sleeve gastrectomy. And this is not just particular in our practice, it's actually nationwide. You can see that the levels of sleeve gastrectomy are much, much higher, right?
It's about 75% overall, and a little bit more for us with the surgery center. So,
yeah. So the sleeve gastrectomy, yeah.
Less complicated, and if they don't have those comorbidities, it's kind of the right way to go. But I was just thinking because, I used to have maybe less interactions with the patients in the last, in the last 3-4 years, I do have more. Because now with the case conferences and having those on a daily basis, so I end up just calling the patient. In some cases, I have like 7-8 other people, but I do pick and choose who to call based on the difficulties they may have. And, patients are pretty opinionated when it comes to what they want. So I was just kind of wondering how open they are to take the recommendation directly if they already make their decision and they don't want to go back.
And after the discussion, we're okay to follow what the patient is comfortable with, as long as there are no major contraindications to do that. As I say, I presented the issue of the Barrett's, for instance, which is an important one, but there may be other considerations as well, which may make a patient really go with one procedure versus the other. So we've talked about the sleeve, where we are removing just the stomach, and then that is really the procedure, and then gastric bypass, where not only we cut the stomach, but we reroute the intestine as well. But both procedures are done laparoscopically, which means we make very small incisions. And in our program, in the vast majority of cases, this is an outpatient procedure, which means patients go home the same day and recover fairly quickly from these procedures as well. Of course, they are surgical procedures. Go ahead.
I was just going to actually, you kind of stole my line on that, because I was just going to talk about how actually straightforward to take care of these patients after the surgery. And we send them home 99.9% of the time. After the operation, it's about 6 hours average that they stay in the surgery center. Yet how much they have to go through to get the surgery done. Yeah. And then also that fear, like if you were to just ask any random person their opinion of how risky bariatric surgery versus a gallbladder, they're going to say, well, bariatric probably is like 10 times more riskier. In fact, that's not the case. Right. Maybe they're even they're maybe same, or maybe bariatric surgery, I would say less, because in many cases, most cases, it's not happening because of the emergency. So we prep the patient for 3 to 6 months. We get all the clearances. So, but yet, patient is discharged same day. So yes. Many people, and it's kind of new because the other day I was looking at one of the marketing materials from one of the hospitals. The way they are emphasizing like the hospital side of it, but we don't want our patients to go to the hospital. This is not a hospital procedure. If it can be done with the team that's specialized in bariatric, this is our boutique. Like no one does this better than we do in anywhere else, like hospital or not hospital. So, and if it can be done in the outpatient setting, and if you can go home on the same day, it tells you, one, it's not too complicated, or is the perception of the complication is not right. And the other thing is, well, you'll go home. So there's no hospital fear of staying in the hospital or getting staph infection at the hospital, and all those issues that you have, complications. So this is the best place to do it. And same day home. So I think that says a lot for those who really want to follow what we are saying. So this is not a procedure where you have to stay in the hospital for a week. So, and then that's what we are prepping the patients for, the clearing process, getting them ready with several different specialties, multidisciplinary approach. And I'm glad that we are able to help those individuals who are choosing the program.
Absolutely. So, as you correctly say, the reason patients are able to go home so swiftly after surgery is because of that extensive preparation beforehand. So that extensive preparation that we put in at the beginning is really to get the patients ready medically, mentally, and in every other way, so that their surgery goes smoothly, their recovery goes smoothly, and they are well prepared, even mentally, to recover very, very quickly. As you mentioned, the vast majority of patients do very well in this setting. Of course, there are patients that would not be appropriate candidates for outpatient surgery, and they have to be done in the hospital. There is no question about that. But the vast majority of patients will be able to be done in an outpatient setting. And then, as you said, there is no exposure to other illnesses that may be circulating in the hospital. And as you said, there is this important component of comfort that patients will experience when they go and have a procedure in a center that specializes in that procedure, where, you know, from the person who greets them at the door of the surgery center to the nurse that helps them get discharged, all they do is bariatric surgery day in and day out. So that level of care, obviously, when it can happen, and in our setting, obviously, it is happening, it will be desired. Who would be against that? There is no question about that, right? But obviously, there are patients who may not qualify for that because they may require higher level of care if they have severe heart disease, severe kidney disease, severe lung disease. In that case, a hospital setting would be appropriate. And obviously, our surgeons are able to work in hospitals. As you know, Korea surgeons have been instrumental in actually building up the bariatric programs in our area, whether it's St. Francis Hospital, Christiana Hospital, Bay Health. Many of the surgeons who work in these places were actually trainees under the Korea surgeons who really have started bariatric surgery in our area about 20 years ago.